You decide on hormone therapy, of course, based on menopausal status and also on what they've had previously. So if you have a premenopausal patient, giving an aromatase inhibitor can be difficult, even with ovarian suppression. 11% or more may not respond appropriately to ovarian suppression. So most of those patients are going to go on either tamoxifen or in the metastatic setting, Faslodex. In the postmenopausal patients, you have a great deal of variety that you can use. And of course, adjuvant therapy is going to be almost always an AI, but you can, with the big 198 trial, you can do switchovers, 5 years of tamoxifen, AI, or 2, 3, whatever you want. In the case of the adjuvant situation in a premenopausal patient, it's going to be 5 versus 10 years of tamoxifen. 10 years, of course, has a small but significant advantage, somewhere around 2-3%. Added side effects, in particular, if they have a uterus. In an older patient, an aromatase inhibitor in the adjuvant setting, traditionally it's recommended 5 years. Studies are pending regarding longer versus shorter AIs. In the metastatic setting, of course, we're dealing with patients with incurable disease. Your sequencing on patients with metastatic disease is very different. In a younger woman who's still premenopausal, you may actually consider taking out the ovaries. Can use ovarian suppression agents, but again, they're not always 100% effective. And again, you're dealing with metastatic disease, so take out the ovaries. In an older patient who's postmenopausal, depends on what she's had before. If they progress on an aromatase inhibitor, and we're talking, of course, postmenopausal, traditionally patients have then been given, if they were on a non-steroidal, they'll be given a steroidal aromatase inhibitor. With recent data from about 2 years ago, of course, the use of mTOR inhibitors plus the exemestane is beneficial in certainly response rates and overall disease-free survival, that using the combined therapy would probably be my next choice. Now the big question comes in about when or how to incorporate Faslodex, and I think many people are reserving that for third line. There will be data coming out soon about Faslodex and mTOR inhibitors. I've used it in patients that, let's say, progressed on exemestane. These are older patients that have been treated previously. So that's how I decide hormonal therapy.